Sir, sir. Hello,
হ্যাঁ মিতু, হ্যালো।
hello.
হ্যাঁ
শুনতে পাচ্ছি,
মিতু
তুমি
বলো।
বলো।
মিতু মনে হয় একটু
I'm
ইন্টারনেট ডিস্টার্ব
Dr.
করতেছে।
Mitulibna, Junior Consultant, Surgery, now in deputation in BSMMU, learning in this breast cancer awareness. Sir, শোনা যাচ্ছে স্যার?
হ্যাঁ শোনা যাচ্ছে।
স্যার, স্যার ঠিক আছে স্যার?
ওকে ওকে,
স্যার ঠিক আছে স্যার?
কন্টিনিউ। হ্যাঁ ঠিক আছে।
ওকে ওকে স্যার। স্যার এখন আই হোপ যে ঠিক আছে স্যার?
হ্যাঁ ঠিক আছে, তুমি স্টার্ট
Okay,
করো।
sir. Thank you, sir. Sorry. Assalamu alaikum and very good evening. And I'm Dr. Mitulibna, Junior Consultant of Surgery, now in deputation in BSMU. Welcoming you all to this weekly scientific, special scientific gathering in this breast cancer awareness month, organized by Society of Surgeons of Bangladesh, courtesy by ACI Pharmaceutical. Thank you, SOSB and ACI. Okay. Here present as our panel of experts, Professor M. Khadimul Islam, sir, Chief Surgeon and of Lab 8 Specialist Hospital, and former Professor and Head of the Department of Sir Solimullah Medical College. Here are another panel of experts, Professor Omar Farooq Yusuf, sir, Consultant Surgeon, CHCR Private Limited, Chittagong, former Professor and
খুব বাজে অবস্থা ম্যামের যদি কথা বলাটা শেষ হয় সেক্ষেত্রে আপনি ম্যামকে কল করে বলবেন যে ইন্টারনেট যে মোবাইলে ডাটা
and Head of the Department of Chittagong Medical College. Professor Kaji Mostaq Hussain, sir, Director of NICRH.
ম্যামের ভিউ হচ্ছে কি দেখা যাচ্ছে না সেক্ষেত্রে এই জন্য
মিতু কন্টিনিউ, প্লিজ আনমিউট আদার ফ্যাকাল্টি, প্লিজ আনমিউট। মিতু প্লিজ কন্টিনিউ।
Professor A.K.M. Daud, sir, Professor and Head of the Department of Surgery, Jalalabad Raghib Rabia Medical College and Hospital. Our today's speaker, two legendary speaker of this today's program, Professor Mohammad Mijanur Rahman, sir, former professor and head of the Department of Surgical Oncology, NRCRH, and another speaker, Professor Dr. Mohammad Mukhlis Uddin, sir, Professor and head of the Department of Oncology, Northeast Medical College and Hospital in Sylhet. This program is chaired by our honorable teacher, Professor A.H.M. Tauhidul Alam, sir, President of SOSB, and here also present our Society Secretary General of SOSB, Dr. Mohammad Noor Hossain Bhuiya Shahin, sir. And here present other my respected teachers and participants. So this is time for welcome speech by Dr. Mohammad Noor Hossain Bhuiya Shahin, sir, Secretary General of SOSB. Shahin, sir, please.
Thank you, Dr. Mitu Devanath, for your nice starting. This is the month of October, is the month of the breast cancer awareness month. We know the pink color is the awareness of the female breast cancer disease patient. Society of Surgeons of Bangladesh always try to involve all of the surgical faculties, all of the discipline to continue the scientific seminar, and also that's why we first start with the colorectal surgery. Now, as it is the breast cancer awareness month, we start the breast cancer surgery. At the beginning, past 14th October, we also start the program, and here and that time the foreign speaker also with us. Now the our speaker we divide it into the surgical and the oncological practice. That's why there is a two presentation. One is the surgical discipline and another is from the oncological discipline. And also our panel of experts from the surgical discipline and oncological discipline. Hope the program will be everybody will enjoy and teach from this session. I thank you very much for the participating in this webinar. Thank you for with us. please continue the next session. Dr. Mitu Devana.
Thanks, sir, for such inspirational speech. And as you know, breast cancer treatment is by multidisciplinary approach. So NCC and AGCC each and every time updating their guidelines. So let us know the current trends of breast cancer surgery, patient-centered management. So may I request our legendary teacher, Professor Mohammad Mizanur Rahman, sir, former professor of and head of the Department of Surgical Oncology, National Institute of Cancer and Research and Hospital, to speak on this topic. Mizan, sir, please. Mizan, sir, please, would you please share your slide?
দেখা যায়?
Everything is okay, sir.
Slide দেখা যাচ্ছে?
Sir, audio visual is okay, sir.
Yes, sir. Okay, দেখা যাচ্ছে, sir.
Okay.
Okay, sir.
Okay. Thank you very much. So, in the month of October, I am here with a pink slide with my title slide. First of all, I must appreciate and pay my gratitude to the SSB authorities, President Professor Dawudul Alam, and Chair of the session, Dr. Shaheen, my panelists, my teachers, Professor Khadimul Islam, Margubhushan sir, and other panelists and learned audiences. Good evening, everybody. So it is very difficult to pack up the huge task, which my course runs in 2 years, to pack up in 20 minutes. Still, I will try my level best. So I will talk on the current trends of breast surgery and patient-centered management. There is no conflict of interest with anybody. This circle you show, which is shown here, it represents nearly 150 years journey. Nearly late 80s, 1800s, it started, and nearly 1900 to 2000, there was tremendous changes. So from the beginning, there was radical mastectomy, then modified radical mastectomy for nearly 50 years. And in 70s, the conservation of the breast surgery started. And in the late part of the 90s, oncoplastic surgery started. And this part, around 20, 25 years, there was tremendous changes in the breast surgery development, in its diagnostic part to treatment. And there is slowly, in the late 2000, possibility of de-escalation. De-escalation in Bangla, ক্ষয়িষ্ণু দেখলাম নিচের দিকে নেমে হচ্ছে, এটা কি কমে যাচ্ছে কিনা? So there is a slowly de-escalation of surgery, surgical role. Now, what is the last part of what is the role of surgery after 2025? So in the last 2 meetings in the St. Gallen, 2017 and 19, there was a recommendation for de-escalation of different parts of surgery, particularly breast and axilla. And in the next meeting, it is that recommendation of continuity. So why breast surgery is so important? Because in the last 20 years, from 1975 to 95, in the 20 years, the survival rate increased tremendously from 75 to over 90%, and 10-year survival over 80%. So patients desire good quality life and sound health. So I am starting my talk on giving 2 scenarios. Here is a patient nearing 25 years old, recently married, no issue. There is a lump nearly 4 centimeters in size in the upper inner quadrant. So it is diagnosed as invasive ductal carcinoma after core biopsy. It was a case of TNBC and axillary node positive. So there are many faculties here. Can you give some options? What is your decisions? It may come from modified radical mastectomy to BCS. Even there may be possibilities of axillary node dissections. So my questions to the House is, what are the difficulties for BCS in this case? The next case is for 55-year-old lady, postmenopausal, mother of 3 children. There is a 2 centimeter lump in the lower quadrant of the breast. Core biopsy revealed invasive ductal carcinoma grade 2, have hormone positive, axilla negative. So what will be the plan of this patient? Will you go for straightway mastectomy or some other thinking processes? If you want to go for think for BCS, what could be the difficulties to face? So if you listen this 20-22 minutes lecture, you can give your opinion, and I'll discuss on this. So there is controversy against mastectomy versus BCS. So in the late 1800s, the whole state started radical mastectomy, and 75 years after, Bernard Fisher, both of Americans, challenged his thoughts like breast cancer. The whole state gave the concept of breast cancer was a localized disease, but Fisher has given the concept that it is a systemic disease. So no issue for doing so big mutilating surgery. In this graph, the contemporary surgeon of Mr. Fisher from Milan, Italy, Mr. Veronesi, there is big data over 25 years ago follow-up. He has shown that radical mastectomy and conservation, the end point is similar. There is no difference between the survival. So survival was equivalent. So if you go for the outcome and quality of life measures after mastectomy, the fetal, the big oncoplastic surgeon from Vienna, has shown 10 big large data. It has been shown that all data nearly 20 or 20 years over follow-up, and mostly the big data. So you can see here nearly 500 in each wing. So he is showing that disease-free survival and overall survival, and and overall survival almost similar. You can see the almost similar. Another one is quality of life questions. So this is a meta-analysis taking 6 studies. This is also big studies. This is the sample size from different parts of the world. They have shown, they have seen the body image outcome and future perspectives. I have taken all these 2. The body outcome on the pooled analysis, you can see that strongly the pooled analysis is diamond is strong, is based on the BCS side. The BCS people liked very much image guidings. Future perspectives. Future perspective বাংলায় আমরা যদি কোনো ক্যান্সার রোগীকে বলি যে আপনার কি হয়েছে, তখন সে খুব দুঃখের সাথে বলে আর কি হবে, আমি তো মরেই যাচ্ছি। আর এক গ্রুপ বলবে না, I got very good treatment, আমি ভালোভাবে বাঁচতে চাই, আমার ছেলে মেয়ে। So these are the future thinkings. The future perspectives দেখা যাচ্ছে in BCS group there is also association in the BCS group. This is what's favor. In Bangladesh, we have got some studies. I personally, with my team, studied in cancer hospital and funded by BMRC and later by DG Health. We could see the quality of life measurements. Sorry. Another one is quality of measurements after neoadjuvant chemotherapy. The 2 wing before mastectomy and after mastectomy. You can see here the after mastectomy all the scores of the components, all components here. Body image, sexual functioning, future parts, everything is there. Deteriorated much more. Even after chemotherapy, the smaller bars after mastectomy, there is much less score in this after mastectomy. So surgeons in that time in the 90s started breast conservation surgery. Breast conservation, in short, it can be told as lumpectomy, coordinectomy, or partial mastectomy in different terms. So BCS done in early breast cancer. Mostly the goal of BCT should be 10-year local recurrence rate, less than 10%. The use of BCT for early stage breast cancer is widely accepted. Now the treatment of choice is worldwide. So BCS comprehends volume, good volume, good shape, good projection, and good symmetry of the both breasts. The clinical informations before going to you should have taken the good family history, pregnancy history, tumor size and locations. I mean, short, this clinical information must be there, and other many other information should be there. There should be a mammogram evaluations of both breasts to know the multicentricity of the disease, status of the contralateral breast, and if is there any placement of any non-palpable lesions. Other features from pathological side, histological type and grade, presence of DCIC or not, and some biological factors. These are very strong factors like ERPR and some tumor predicting proliferation factors as well. So patient's preference is very important for decision making. এখানে অনেক ফুল আছে, বিভিন্ন রঙের ফুল আছে. Like this, you have to tell the patients the different choices, and patients will discuss risks and benefits of everything, and patient will give your opinion. So factors to be considered are long-term survival, the possibility and consequences of local recurrence, and psychological adjustments. Absolute contraindications are pregnancy, multicentricity, prior therapeutic radiation, and persistent positive margins. I'm not going for relative contraindications, but small and large size breasts are not a very good candidate for traditional BCS. So family history must be there. If there is any positive history, positive family history, it is not a straightforward a contraindication for BCS. So utilities of neoadjuvant chemotherapy, monitoring the treatment response, promoting the precision or de-escalation surgery of breast and axilla, prediction of recurrence by measuring residual cancer burden, and timing for genetic testing in this period. So there is now a good option for nowadays a marker placement in the tumor, especially it is in practice in before starting the neoadjuvant chemotherapy, especially the smaller tumors, if it is less than 5 centimeters, because there are chances of disappearance of the tumors. There are many debates of frozen section. The marker clips to be placed even after surgery as well, to facilitate the radiation therapy and radiation oncology. Now, if he talks about axillary surgery, the management of it is part and parcel of breast surgery. It is level 2 axillary dissection, provide accurate staging information and maintain local control in the axilla. So there are many complications. Of them is lymphedema, disastrous complication. Others are numbness, some neurological pains, and frozen shoulders deformities. Thinking all this, surgeons from Milan in the 90s started the sentinel node biopsy for node negative cancers. And patients with positive nodes was recommended for axillary resection. There are some meta-analysis for identification, rate of identification in sentinel biopsy. So almost 90% accuracy, 10% positive false negative ratios. And there are some newer things that they used mostly methyl blue dyes and radioisotopes. And there are some newer things. I'm not going into details of it, but I put place one thing, that is ICG, indocyanine green dye versus blue dye. There is a comparative study here. In indocyanine green, there is 99% of positivity. আমি এটা বলছি এই কারণে এই মুহূর্তে আমাদের দেশে 4টা হাসপাতালে এই মেশিনটা আছে, সবাই শুনেন, শাহিন ভালো করে শুনেন। ঢাকা মেডিকেল কলেজ, শেখ হাসিনা বার্ন ইউনিট, চিটাগাং মেডিকেল কলেজ এবং ক্যান্সার ইনস্টিটিউট। এই মেশিনে কোটি টাকার মেশিন কিন্তু আনইউজড পড়ে আছে। এই মেশিনটা এই ইন্ডোসাইন গ্রিন ইট ক্যান বি কম্পারেবল উইথ রেডিওকলয়েড। রেডিওকলয়েড ব্যবহার করা সহজ নয়। ইন্ডোসাইন গ্রিটা লো কস্ট একটা জিনিস, মেশিনটা পড়ে আছে। প্লিজ যদি আমার কোনো হেল্প লাগে ফর টেকনিক্যাল, আই উইল বি দেয়ার। This is the last trial of axillary dissection at Buliano, G11 বলা হয় এটাকে। So 10-year disease-free survival, it almost have shown that SLN is a bit superior than axillary dissection after the causes. This slide is taken from our places. Now precision surgery. এই ছবিটা আপনারা যারা নতুন জেনারেশন তারা দেখে নাই। His master's voice আগে আমরা যারা গ্রামের বড় মাতব্বর তারা গান শুনতো, 2-3 আশপাশে 2-3 গ্রামের লোকজনও শুনতো। কিন্তু nowadays what happens, আমি একা শুনতে চাই, ইউটিউব থেকে একটা গান শুনতে চাই, সেটার উপায় কি? এই ছোট্ট একটা যন্ত্র যেটাতে আমরা সবাই শুনতে পাবো। This is precision, যেটাকে আমরা অনেক সময় precision medicine বা personalized medicine বলি। সেটা that also can also be applied in case of surgery as well. In the breast surgery as well as, so breast size where screening mammogram is executed, 25 to 30% of the cases are non-favorable lesions. So So in that case can be managed by placing some wires, image guided surgery as well at Korasham. So it is pre-operative placement of the wire and post-operative view of a specimen mammogram, specimen X-ray as well. So wire localization is the technique available in nowadays in our country in the NI series as well as some private centers. I have taken the slides from NI series already started, and this is a placement of a marker. There are different types of markers in the market, which is placed in the neoadjuvant setting as well as smaller lesions. Now, targeted axillary dissection. There are many words on this, like targeted therapy. There are targeted axillary dissection as well. Marking nodes with biopsy-confirmed metastatic disease allows for selective removal and improves pathological evaluation for residual nodal disease and chemotherapy. So the false negative ratio for AAD is 2%, but in place of 10% in SLN. So this is a picture of this targeted season. In the node, there is a small clips inside. This is also a picture of post-operative view of so precision surgery is becoming more. So surgery is going to be omitted. There is also some studies. After getting clinical response, this blue is for surgery, this is yellow for non-surgery. This for 45 surgery and 51 non-surgery. At the end of 4 years, that was the Dutari survival almost similar. So what happens? Surgery is going to end. Surgery de-escalation. So we can see the picture. Surgery is going to die. So so there may be new start of the surgery domain. Surgery. So problems of BCS are there. Maybe more chances of 30% residual deformities. There may be retraction displacement. Noise. So problems of BCS are the more chances of residual deformities and displacement of NSC, and there may be asymmetries. So there you can see here, there is big dimpling and there are barred big deformities. So it is also BCS, but it is not, gives no beauty. That's why the emergence of oncoloplasties came in the mid-90s. So before going to that, there is a meta-analysis of a comparison between BCS and oncoloplastic techniques. I'm taking the pictures of lump size, margin positivity, re-excision rate. You can see all the parameters in oncoloplasty is superior than the VCT alone. Even the complications rate, satisfaction, and also superior if you compare with the VCT. So by definition, oncoloplastic techniques comes from a combination of oncoplasty, oncology, and plastic techniques. The address from German who combined to both groups of plastic surgeon and breast surgeons. The oncoplastic surgeons are basically of two types: volume displacement and volume replacement techniques. And indications mostly in oncoplastics are when the tumor size, tumor weight less than more than 10% of the breast volume, or when the resection needs to be over 20%. In these cases, the oncoplastics is needed. In short, the algorithms here shows if a small resection planned in a small breast, standard VCT can serve the purpose. If the large breast, oncoplasty is needed. For larger resections, for a small breast, it is not possible. The mastectomy indicated, but for larger breast, oncoplastic techniques should be applied. So level of oncoplasty is there be level 1 if it is less than 20%, and if the more than 20% is volume to exercise, then it is called volume level to excision. The definition given by Mr. Krishna Cloud, famous oncologist surgeon from Paris. The following points to be considered: volume of tissue exercise, tumor location, breast size, and glandularity. Some of the pictures of oncoplasty techniques of like it can be divided into vertical and horizontal techniques according to their scar presentations. There is more thermoglandular mobilization is needed, and some vertical techniques as well. It can also be named on the basis of their pedicles, like superior pedicle, inferior pedicle. There is this medial pedicle, This is the inferior pedicle. This animated picture that you can show here beautifully placed. In the inferior pedicle, the volume of tissue from inferior part of the excised, and after that, the bilateral ejection myoplasty of a large breast here. So marking is important element of these oncoplastic techniques. After again, there's a bilateral reduction of plastic the breast sizes here. Apart from this technique, there are some autologous tissue to be transferred in the volume replacement chapters of the oncoplastic technique. This is the picture of LD flap. This is tram flap, and there are some other flaps like deep inferior epigastric and superior gluteal perforator and deep inferior gluteal perforator flaps. So there are many types of flaps out there. Then another term is conservative mastectomies. This is called new surgical procedures. It includes the skin and nipple sparing mastectomies. This is very emerging and very nowadays is becoming very popular in Western worlds. After the advent of the prophylactic mastectomies, along with this, implants are used in nearly more than 1 million implants are nowadays used worldwide. Skin and nipple sparing mastectomy nowadays gradually become popular. And after nipple sparing and implant use, this is a post-operative view of a patient. So beautiful breast should be there, good have a good size, fullness, projection, good nipple position, and good symmetrization. So some of our cases I'm going to show here. It is a young lady, hormone positive, invasive duct cell carcinoma. We planned for a plastic procedure. This is lateral mammoplasty. We excised large amount of tissue and went to the axilla in the same incision. More than 20% of the tissue is removed with a de-epithelialization. This contour is well maintained. The radiation is a problem for this patient. My colleague, Professor Mokhlis, then will be talking on this. After radiation, every breast becomes shrunken, skin becomes color change and thicken. So you have to counsel the patient first. So after 9 months, now after 18 months, this is the picture of the breast almost So this is a second case. This is another smaller breast tumor on the inner side. This is a difficult case for this patient. So hemipatric incision, we could excise more than 30% of the tissues. So it is another incision in the 12 o'clock position after the total reconstruction. This is a large breast, tumor placed in the 6 o'clock position, hormone positive. A good amount of breast tissue was removed. So after it is inverted T incision after the repair, after reconstruction. This is preoperative and this is post-operative view of this patient. This is a total dermoglandular mobilization of a central tumor, NSC excised, and this part of the skin is mobilized here. It is called grissotive flap as a new areole is formed. So in short, this is our, I am to show few cases. We are practicing it. For surgeons, I am going to different domains now. More than 20 years back in UK, there is a big issue of a famous surgeon. He was a very surgeon. He didn't follow any guideline on protocol. He used to do many mastectomies. So over treatment and its sequelae, it is a news item. More than 1,000 mastectomy patients sued for compensation, and he had to pay nearly 37 lakh pounds along with 20 years custody. So this is a message for practice of what we are going to do. There are many issues in breast surgery nowadays in practicing in Western world. Number one, shared decision making. What is that? Shared decision making. It is the process in which clinicians allowing the patients work together for different tests, treatment, management, support packages, etc. It involves the provision of evidence-based information about options, outcomes, and uncertainties about the patient's entities. So this is the picture of clinician's role, patient's role, and shared decision. There may be some external influences like families, etc. Nowadays, Dr. Google plays a very key role for this shared decision making. This is taken from the BMJ, and this is Glenn Eloin is a masterpiece. We have opportunity to hear his talk. It will take huge time, so I'm skipping this slide. Another one is shared decision making is MDT meeting. It is practiced in many countries, even in India. The surgeon, radiation oncologist, pathologist, breast nurse, and radiologist all together, along with the evidence-based medicine, they have to take the decision. Another one is advocacy and support group in the different world. There are many supporting groups are already there to support the caregivers and patients and their families. Now I'm coming towards by ending of this session. There are some education and training on breast surgery. What is the scenario of this? Now, according to the globe scenarios of the globes, there is no degree on breast itself, but there is degree on breast and others like breast and endocrine. India, in some places, there is degree. There are masters and diploma on oncoplastic surgery. In East Anglia University, UK, they are India and Arab Emirates, they are the partners. In the Barcelona, there is a diploma. There are some certification courses and fellowships in Europe, Brazil, US, etc. But there are some breast institutes and courses like UK. In NHS, they works Association of Breast Surgery. There is an educational wing. There are some course curriculums. And in Paris, there is a big institute. German, Milan, Brussels. There are independent courses and fellowship programs. Then there is Istanbul and Brazil and Pune, India. They have got their education academy for courses. This red mark, I am pleased to inform you that this red mark areas, we have already connectivity with them. They are taking our classes. I am coming to that. The European Society of Surgical Oncology, they have made an examination for certification courses. This is called BRESO. There is a course curriculum published in January 20, and for this, they have, after 4 years after general surgery training, 2 years breast and specialized designated unit. Thereafter, 1 year after that unit, they have to work. After that, they can qualify for this examination. So there is a breast unit in Isuma. In Bangladesh, we are trying to struggling to make a institution like this. From January 19, we started a training center for Bangladesh School of Oncology Surgery under the patronization of Organization of Bangladesh Cancer Society. We started a comprehensive course matching with the breast examination. The candidates are selected from the general surgery, surgical oncology, and plastic surgery, and those who are practicing breast surgery for more than 2 years. But in the first class, we had 18 members. In second class, we had 24 members, all working in throughout the Bangladesh in different institutions. So this year, after the Corona era, still we are not stopping our class. The Indian Institute Pune have taken already 8 classes. Turkey Institute 2, and there we have attended extensive conferences of Turkey. UK we gave two classes, and we have more opportunities to different world faculties and fellowships for them. So this is the pictures of the last Turkey conferences. Memorandum signed by the Pune Institute. Last conference attended by in our Bangladesh. That was the first conference workshop we made it. This year, the February 20, we could make a program with European Society of Surgical Oncology in program of advanced oncoplasty with my school members in Jaipur, India, and they gave a slot for half an hour. So my school, my girls and my members performed very well. So it is possibly this should be the today's title slide. Above all, or construction, this baby could not, the mother still cannot be able to feed her baby. So the take-home messages are every breast cancer patient deserves oncoplasty. We should need the biology is the king of any cancer treatment, like breast conservation. So all patients to be stratified, seeing their pathology report and tumor biology. So every surgeon should achieve competence on mastectomy and axillary dissection surgery before jumping to any advanced techniques. So surgery is coming in a new horizon. So surgery is not end. So at the end, think twice before putting your knife over the patients. This is my last message. So thanks for your kind attention to give me the floor This is my email for educational purposes. Those who ask the questions, because it's a platform. এখানে একটা controversial issue নিয়ে অনেক কথা বলেছি, অনেক কোশ্চেন থাকবে, আনসার করা মুশকিল। আমি চাইবো যে এখানে এসএসবি এর অথরিটি আছেন, রিগার্ডিং দ্য ডেভেলপমেন্ট অফ দিস সাবজেক্ট আমাদের অনেক কিছু বলার আছে। বেশি সাবজেক্টের কথা না বলে এই পলিসি মেকিং কথা নিয়ে যদি বলেন, আই উইল বি হ্যাপি। থ্যাংক ইউ এভরিওয়ান। আমি শেয়ার ছেড়ে দিচ্ছি।
Okay. Me too.
Okay, sir. Sir, thank you, sir, for your nice and extraordinary, as usual, presentation. Sir tried to cover every aspect of surgery within this short time. Thank you, sir. If it in details, then, but due to time constraints, sir might not be able, whatever. So please put your question in our chat box, please, and which will be discussed later on in our question and answer session. Another important team member in this multidisciplinary team is oncology, definitely. So may I request our, right, sir. So may I request our today's another presenter, Professor Dr. Mohammad Mukhlisuddin, sir, to present on.
Am I audible to you?
Right, sir.
Can you see the screen?
Thank you, sir. Sir.
Okay.
Right, sir.
Thanks, the Society of Surgeons of Bangladesh, for organizing this seminar on breast cancer and allowing me to say something regarding the recent trends of oncologic management of breast cancer. As you know that breast cancer is the commonest malignancy globally, and 1 out of 8 ladies became the victim of breast cancer. The peculiarity of our country is that, irrespective of other countries, the patients of our country are a bit younger age group. This is the peculiarity of the patients suffering from breast cancer of our country. Now, breast cancer incidence is increasing gradually. At the same time, death rate is declining. Around 24 to 30% death rate has declined during the next 2 to 3 decades due to improvement in diagnostic facilities such as histology, molecular subtyping, immunohistochemistry, better surgical management, also early detection by screening, then surgical skillness, then newer chemotherapeutic agents, immunotherapy and targeted agents, and also newer techniques for radiation treatment facilities. However, regarding the breast cancer, in situ and infiltrating, these are the pathological basis. Usually duct cell carcinoma in situ, this is the common, maybe lobular, but these are fewer. Peculiarity of in situ duct cell carcinoma is that 40% remain in situ, don't go into invasive form. And among the infiltrative form, the infiltrating carcinoma is the commonest, followed by infiltrating lobular and others. Regarding pathology, a few words, the majorities are hormone positive, around 15 to 20% are HER2 enriched, and finally TNBC 10 to 15%. For treatment purposes, we in fact now break it on molecular basis into basal-like and non-basal-like. Among the non-basal-like, luminal A, commonest, more than 40%, luminal B, and HER2 enriched. These are the times, I am not going inside due to shortage of time. Now, regarding staging, I am also not going inside, just showing the table of staging T, N, and M, staging status. Diagrammatic representation of staging of breast cancer due to shortage of time, I am not going. Now, regarding the treatment, duct cell in situ carcinoma, as per NCCN guideline published in September 2020, they have instructed that even in situ cancer, before starting treatment, complete history physical examination diagnostic bilateral mammography, pathology, review, immunohistochemistry, everything to be done before starting treatment, and on the basis of which planning is to be done. As per NCCN guideline, treatment are conservative surgery followed by whole breast irradiations, total mastectomy with reconstruction, conservative surgery with accelerated partial breast irradiations, and in very limited cases, only no need of radiation therapy, especially those who are extremely aged, that is more than 70 years, as because these are very, very slow growing and hormone positive. Now, after surgery, further treatment for risk reductions for ipsilateral breast cancer, these are 10 years for hormone positive cases. For premenopausal, tamoxifen for 5 years. For postmenopausal, amoxifen or aromatase inhibitors. Aromatase acts a bit better, but have delayed bone-related toxicities more. This is the NCCN flow chart NCCN. Now, to breast cancer, that is stage 1 to stage 3. Again, NCCN guideline has instructed to do thorough investigations, screening mammogram, diagnostic mammogram, ultrasonogram, needle biopsy, including immunohistochemistry. For palpable breast, triple assessment, that is clinical examination, breast imaging, core needle biopsy, including immunohistochemistry, and then staging investigations. Now, treatment guideline as per NCCN guideline, local regional treatment. One is conservative surgery with surgical axillary staging. In that case, all the patients should get whole breast irradiations. And accelerated partial breast irradiation if there is no node and if the patient is aged, in that cases can be done. Another option is with reconstruction. And after mastectomy, radiation is indicated when more than 4 axillary nodes are positive. 1 to 3 axillary positive nodes. NCCN guidelines has instructed to give radiations. Node negative tumor size more than 5 centimeters, that is T3, radiation to be given locoregionally. Positive resection margin, this is the indications of radiations. Tumor up to 5 centimeters but close margin, radiation is indicated. Central or medially located tumor may be smaller up to 2 centimeters along with high risk group. Though T is small, even into a T2, radiation is indicated. Only not negative, but tumor size up to 5 centimeters with wide margin. Here, no need of radiation therapy. This is the flowchart for early breast cancer management, surgery followed by adjuvant therapy. But nowadays, high risk breast cancer such as TNBC and HER2 enriched, here for T2 lesion that is more than 5 centimeters. Neoadjuvant chemotherapy is indicated, followed by surgery and other adjuvant therapy. Now, what is adjuvant therapy? Treatment adjuvant treatment given after definitive therapy when there is no grossly detectable disease. Intention is to sterilize metastasis, which are the unknown field of treatment. And it helps to prevent the local, regional, or systemic recurrences. And given in patients with high risk of recurrences, possibility risk of recurrences, usually after completions of optimal definitive treatment, where there is no, this is important, no radiological, physical, or investigational or serological evidence of disease. This is adjuvant therapy. That means there is axillary mass and I am giving treatment, radiation chemotherapy. This is not adjuvant, and there should be no even serological evidence of disease. This is the adjuvant. It offers us to reduce the recurrence, locoregional 20 to 30%, and reduce the risk of death by 7 to 11%. This is the achievement of adjuvant therapy. Now, types of adjuvant is local
You are too beautiful.
and systemic. Locoregional by radiation, systemic, chemo, hormone, targeted, and immunotherapy. Timing usually after 3 weeks. Sometimes we give radiation first, sometimes we give chemotherapy first. Chemotherapy first is preferred when the disease is high grade. And radiation first if it is slow growing, somewhat like this. Adjuvant radiation therapy indication after conservative surgery and after mastectomy. These are the indications of, as Professor Mizan has told, the indications of conservative, absolute indications of conservative surgery. These are relative indications of conservative surgery. Now, after breast conservative surgery, usually the whole breast, 50 grade to whole breast, and for invasive diseases, boosting is done, not for in situ. Boosting by around 20 grade, 15 to 20 grade. This can be done by electron boost or by special perioperative or post-operative coning down of the photon beams by that day. Local recurrence 43%. Now, radiation after mastectomy, if the 4 axillary nodes, even a single node with extra capsular extension, if present, then radiation is indicated. Very close or positive resection margin. TXNX is high in the past. Nowadays, TXNS has reduced drastically. That means tumor and nodal status. Nowadays, we are getting information due to improvement in surgical consciousness and also the pathological reporting improvement. TXNS has reduced drastically to great extent. Now, for those for need the boosting, only the chest wall irradiate 50 gray by conventional fractions. Toxicity by radiation has been reduced to great extent by newer radiation such as IMRT, IGRT, 3D CRT radiations. Indications of adjuvant radiotherapy. Has been some sense. In the past, we would tell that all patients will need adjuvant chemotherapy, except if the tumor is less than 1 centimeter. Of same patient, there should be no of same patient should be hormone positive, and grade should be low, and patient should be elderly. Nowadays, due to molecular study, for better understanding, we are able to know the low risk group, that is better prognostic group, such as in that cases, hormone positive to 3 centimeter tumor size after surgery, no need of chemotherapy, just adjuvant hormone therapy is sufficient. This is newer introduction. Now, as per NCCN guideline, after surgery, so for operable breast cancer therapy is indicated in case of triple positive, that is hormone also HER2 positive, up to 0.5 centimeter, hormone plus trastuzumab with or without chemotherapy, but more than 0.5 centimeter in all the cases, both trastuzumab for 1 year and also chemotherapy. The hormone positive but HER2 negative, better prognostic group, for 0.5 centimeter endocrine therapy, or more than 1 centimeter adjuvant chemotherapy, and also then hormone therapy, and February histology up to 3 centimeter, no need of chemotherapy, only hormone therapy. Now, HER2 enriched breast cancer in adjuvant chemotherapy is up to 0.5 centimeter adjuvant chemotherapy with trastuzumab, and of that also adjuvant chemotherapy trastuzumab. All the cases, both chemotherapy and trastuzumab is to be added. These are the guidelines, ancient guidelines. Now, TNBC, systemic chemotherapy is the only hope.
স্যার
And
মুখলেস স্যার,
জি,
স্যার প্লিজ একটু স্যার, আফজাল তুমি সবাইকে
সাজেদ নামে একজন লোক আছে যিনি কিছুক্ষণের জন্য মাইক্রোফোনটা আনমিউট করে গান গিয়ে তারপরে আবার মাইক্রোফোনটা মিউট করে ফেলে।
উনাকে টোটালি স্টপ করে
পাইলাম
দাও।
না।
Why don't you block him?
উনাকে টোটালি ব্লক করে দাও, ওনাকে স্টপ করে দাও, ঠিক আছে?
স্যার আমি ওনাকে
Yeah.
খুঁজতেছি। ওকে স্যার।
ওকে স্যার,
For
কন্টিনিউ করুন।
TNBC, if the tumor is less than up to 0.5 centimeter, no need of adjuvant therapy. But adjuvant chemotherapy is to be added if tumor is more than 0.5 centimeter and above. For hormone positive and HER2 negative, that is favorable up to 0.1 centimeter, adjuvant endocrine therapy. That is favorable histology up to 3 centimeter. This is a new message that after surgery, no need of chemotherapy. Give adjuvant endocrine therapy. Chemotherapy is added when node positive. This is a new message from NCCN guideline. Standard for hormone positive and HER2 negative, that is same. These are the a few protocols. These are the protocols. I'm not going in details. This is for only for us, such as TAC, AC followed by TA. It may be boring for others. That is why I'm not going there. And then, as these are the hormone positive, so these are the options for hormone therapy. Premenopausal tamoxifen, 5 years for low risk group and 10 years for high risk group. For postmenopausal tamoxifen or as aromatase inhibitor. But one thing is that aromatase inhibitor should not be given more than 5 years, as because it causes weakening of the bone. If we give aromatase inhibitor 5 years, we shall be shifted to tamoxifen again. That is by both the groups we can go up to 10 years of hormone therapy. These are the guidelines for HER2 positive operable breast cancer. Here, tumor more than 2 centimeter, surgery is discouraged, but a neoadjuvant chemotherapy is given, and then surgery, and then further adjuvant therapy as per protocol. Chemotherapy for early stage HER2 positive operable HER2 positive breast cancer. These are the HER2 positive breast cancer protocols. That is chemotherapy with trastuzumab, dose dense SC followed by taxane with trastuzumab. We actually inhibit to give trastuzumab with doxycycline or with adriamycin, as because both are cardiotoxic. That is why one point we always try to remember that it should not be given with docetaxel. So these are the protocols. TNBC, that is the chemotherapy is the main protocol. Even after more than 0.5 centimeter chemotherapy, they indicate these are the protocols. I am not going in details. For postmenopausal women, those who get especially the hormone therapy, then bone supporting treatment is needed. As per NCCN guideline, some cases that are high risk group, that is the TNBC and HER2 enriched. Here, the surgery and adjuvant therapy কিরকম হবে NCCN গাইডলাইন কিছুটা গাইডলাইন দিয়েছে যে নিওঅ্যাডজুভেন্ট থেরাপি যেটা দিলাম হাই রিস্ক গ্রুপের জন্য, এটা নতুন মেসেজ ফর্মে আসছে যে যদি কমপ্লিট বা পার্শিয়াল রেসপন্স হয়ে থাকে তাহলে এরপরে আমরা সার্জারি করব, সার্জারি পরে আমরা কেমো এবং রেডিয়েশন দেব। আর যদি কিনা পার্শিয়াল রেসপন্স বা প্রোগ্রেশন হয় তখন আমরা কনজারভেটিভ স্কোপি নেই, আমরা ম্যাস্টেক্টমি উইথ রিকনস্ট্রাকশন অ্যাডভাইস করা আছে, তার সাথে অ্যাডজুভেন্ট থেরাপি, অ্যাডজুভেন্ট কেমোথেরাপি এবং অ্যাডজুভেন্ট রেডিয়েশন থেরাপি এগুলো চলে আসবে। Now, locally advanced breast cancer. Locally advanced breast cancer, T3, T4D, N3, medical notes, M0. These are treatment guidelines or flowcharts for management of locally advanced breast cancer. Neoadjuvant chemotherapy followed by surgery and then as adjuvant and further treatments. And NCCN guideline regarding locally advanced breast cancer. The flowchart is complex, that is why I try to make it simpler form. In local advanced breast cancer, after NSCT, if the response is good, then mastectomy with reconstruction or conservative surgery with accelerated, and then adjuvant systemic therapy and adjuvant additions. In NSCT, if response is not so much good, additional systemic therapy or systemic therapy with change protocol, and then surgery, and then other systemic therapy. If no response, then individualized decisions. Adjuvant systemic NCCN guideline, I am going outside. And a few guidelines has been given in the form of preoperative oblique adjuvant therapy regimens for locally advanced breast cancers. These are the HER2 negative, these are the preferred options as usual. The HER2 negative AC followed by T, somewhat like this. HER2 negative, these are the protocols. Positive, same chemotherapy with trastuzumab, that is targeted therapy based. There are different protocols. HER2 positive cases, neoadjuvant chemotherapy complete response যদি করে থাকে তাহলে neoadjuvant chemotherapy তাহলে পরে অ্যান্টি HER2টা 1 ইয়ার পর্যন্ত কন্টিনিউ করতে বলছে। যদি রেসিডিউ থাকে তাহলে বেটার টু সুইচ ওভার টু TDM1. NBC, these are the treatment guidelines, preoperative and postoperative. It's all the same protocols. These are now the rationale of neoadjuvant therapy. Rationally for principles for neoadjuvant therapy, because it helps to increase the rate of breast conservation, converts inoperable into operable phase, prognostic information we obtain, especially for NBC and enriched types. Non-responsive, we can get scope to change the schedule. Those who become pathological complete responder are the long-term survivor. We can predict, especially in case of NBC and HER2, we can change the protocols. Now, who will get neoadjuvant chemotherapy in inflammatory breast cancer as per NCCN guideline? N2 or more, N3, tumors. These are the, and those patients who should not get neoadjuvant systemic therapy, patients with extensive in situ diseases, patients with poorly delineated extents, patients whose tumors are not palpable or clinically accessible. In that case, neoadjuvant chemotherapy has been discouraged. Now, the metastatic breast cancer. In metastatic breast cancer, we usually divide them low risk and high risk group. Low risk group usually the single organ involvement, not multiple organs, especially the bone and the receptor positives, hormone receptor positives. We try to treat, treatment guideline is to try first with hormone therapy. If fails, then chemotherapy, and medium and high risk group with chemotherapy. Radiation is selective for emergency purposes such as bony pain, fracture, cord compressions, SBO, this. Now, receptor positive metastatic breast cancer guidelines are low risk group. Try to start with first line hormone therapy. If responsive, continue. When non-responsive, then second line hormone therapy. If responsive, continue. When it does not respond, then third line hormone therapy and then chemotherapy. And when it will not be responsive, only 40% symptomatic treatment. For metastatic triple negative breast cancer, these are the options. Nab-paclitaxel, AC followed by TIP, FAC on oral chemotherapy such as that is olaparib. Then immunotherapy, atezolizumab, or and one information is that those who are hereditary breast cancer, BRCA positive, cisplatin is the highly sensitive drug. In so many trials, it acts more and better than those of the other chemotherapy. And so this is simple agent, but acts very nice in case of BRCA positive cases. This is a message. Now for positive cases, that is hormone and same protocol. Now we have come to the end of our presentations. Response is good when the disease in early stage. Response is not advanced stage. So for breast cancer, this is the breast cancer awareness month. So for breast cancer, early detection for getting better response is essential. So we shall try to detect breast cancer in early stages by increasing our screening program to the root level of our country if possible, and public awareness to avoid the etiological factors related with development of breast cancers. Thanks for patient sharing.
Thanks, Mukhlis sir. Definitely, sir and everyone were interrupted by someone intentional activity. I hope so. So whatever. There are some questions in chat box. This is question and answer session. I am requesting everyone of the participants and our teachers and every participants to make question in our chat box, please. And there is already one question to Ms. Ansar, please. What setup is needed to do SLNB in our practices available? From Dr. Sharnas Parvin. Ms. Ansar, please. Hello.
Can you hear me?
Sir.
Sir.
Please, sir. This, sir.
Sir, one question from Sharnas Parvin. Question is, what setup is needed to do SLNB in our practices available?
What setup?
Right, sir.
It can be done in our existing setup. Only there is a problem of if you ask for frozen biopsy. Existing setup, if you want to know frozen, SLNB can be done in different way, like pre-chemo, in between of and afterwards. If you want or seek for frozen biopsy, then you should have these facilities. And if you can even before giving chemotherapy under local anesthesia, then there is no problem.
Sir, there is a limitation because after any city, there is more chance of false negativity. Is it? What is your experience, sir? Can we overcome, sir?
এনএসসিটির পরে আমাদের এক্সপেরিয়েন্স খুব লিমিটেড, যেগুলো বইয়ে কেতাবে বলে আর কি, তাদের তো খুব একটা সমস্যা হয় না।
Okay, sir. But we need frozen section facilities, and if dual dye or gamma is available, then more perfect and percentage of the SLNB is more perfect.
Identification আমাদের even the blue dye which is available in our country. That is not also good. And
Right,
even
sir.
college but newer item, those who went visited AIMS, they are using dyes. That is also
Right,
what
sir.
I have some experiences that works well. And the institutions where this machine for ICG is available, they can use it. I think it's good. And in near future, possibly we'll get radio colloid. There is a lot of hassles are there. So in our situation, we can use methylene blue. Isocyanates blue is not available in our country.
And frozen section facilities also, I think, is very important for the setup and in simultaneously doing operation on the breast also at the same time. I think on the setup is very important, right, sir? So another question to Mizan sir is from inquiry, sir. The targeted lymph node excision, sirs, but how one will be able to know how much lymph nodes are involved? That means metastatic. So
it is done. It is during introduction of the biopsy is done, and on the basis of the biopsy, the clip is inserted. And thereafter, under ultrasonic guidance, it is practiced.
Okay, thank you, sir.
So it is not very far. আমাদের হাতে আগামী
Evidence of primary in the breast. What is the plan now?
That is a different issue. We must have to look for the primaries. Even if traditional investigation fails, you should seek help of MRI. Until stone you should have to look for it. There is somewhere deletion. In many times, deletion may not be palpable, may not be detected in traditional investigations.
Okay, sir. Mukhlis, sir, from this point of view, I just expect some comments for the regarding this question, sir. Mukhlis, sir, please.
Question?
Sir, axillary node is palpable, and excision biopsy histopathology is metastatic breast cancer, but there is no evidence of primary in the breast. What is the plan now?
Guideline reveals that mastectomy with axillary dissection is the answer. No.
Okay, Mizan sir, do you agree?
Any opinion from the other faculties also?
Other faculties also. I
wanted to say something.
And
give him chance, Dr. Farid.
Khadem sir and our panel of experts.
Am I allowed to speak?
Yes.
Right,
Or is it only the faculty?
No. Anybody.
Thank you very much. Excellent program. I want to make comments on all the questions that were asked. First question was asked about sentinel biopsy facilities. There is definitely no need to have a frozen section facilities for every sentinel. No need to do axillary clearance. The answer is patient definitely needs treatment. Number one, inflammatory pressure. Number two, more cancer more than T2, that is bigger than T2. Number three, near-adjuvant chemo. if post-neoadjuvant chemo patient is getting a sentinel biopsy, that has to have a frozen section, because if that frozen section shows cancer positive node, then that patient definitely needs axillary clearance. So these are the exceptions. Apart from those exceptions, there is no need to have frozen section, and that is the current practice all the developed countries. Second question was an interesting one. We come across axillary palpable mass with normal breast on clinical, mammographic, and ultrasonic findings. And you do FNC or core biopsy of that axillary node is metastatic breast cancer. And this is a dilemma all over the world, not only in Bangladesh, also in UK. I've got 500 cases every year. We will come across 1 or 2 cases every year. Professor Mizan has rightly said that MRI breast is an answer. I assume that patient must have had a mammogram and baseline ultrasound both done, and clinical examination. Even if 3 is normal, you would almost always find MRI guided biopsy confirming there is a small cancer. And there are situations where MRI also fails to detect a breast cancer. Clinically, mammographically, ultrasonically, all breast is normal, but axillary is positive. Then obviously, Professor Mukles, as he said, needs axillary clearance. And I would go for that as well. And there is no need to do breast surgery, just needs annual mammographic surveillance alongside MRI. Thank you very much.
Thank you, sir, for
Thank
your
you very
nice
much.
comment,
Nitu, continue.
sir. Sir, yeah, from this view, I'm expecting some comments from our panel of experts and our teachers or anyone, please. Would you please share? Khadim sir, please.
Sir, Professor Khadim Islam, please unmute yourself, sir. We cannot listen you. We cannot hear you. Unmute, sir. Please.
But as a participant, not as a panelist, I really enjoyed the session. But unfortunately, someone has intervened during the presentation of Professor Mokles, and I think everybody's screen showed that nuisance. And how did it happen? I don't know. But really, that caused a lot of distraction. About the comment regarding the sentinel node biopsy, I think Dr. Farid has nicely answered the question. About the second point, that is the palpable axillary lump or axillary on excision biopsy showing metastatic cancer, and then what to do. But I think nowadays one should not proceed for excision of axillary lump without going through FNEC or two-cut biopsy. So if that is omitted, then it is an old style practice that there is a lump in the axilla, get it out and sort it out, what is the nature of the lump. But ideally, it should be FNEC, and that FNEC is enough to prove that it is a metastasis or not, or if necessary, the targeted core biopsy. And then definitely the breast should be the organ to be screened by all possible ways, the sonology, the mammography. If they fail, then definitely the MRI. And if MRI also fails to identify any primary focus in the breast, so there is no justification of removing the breast. Definitely, one should go for axillary clearance and then putting the patient uh, under surveillance, and based on the histology and the molecular study of the node, then subsequent the adjuvant therapy should be I think in these circumstances, this should be the way of management. Unnecessarily, the breast should not be excised. Thank you.
Thank you, sir. Thank you, sir. Omar Farooq Yusuf, sir.
Sorry, can
do
I
you
speak?
sir, Yusuf, sir, sir, axillary lymph node positive, but no lump in breast or in MRI even. So, sir.
Mitra, I think about the axillary lump positive and the breast negative, he already clear. You
Okay,
choose
sir.
to another question to the
Another question. Okay, sir. There is another question from me, sir. Because of illiteracy and economic constraints of our country, and most of the people came to our hospital and in our government setup. Because of that, those patients who might not come for regular follow-up, and so breast conservative surgery, onchoplasty versus mastectomy, in our perspective, what should we prefer? Yusuf, sir, please. Your experience, please.
Thank you very much. Can you please repeat the question again?
So because of our illiteracy and economic constraints, those patients who might not come for regular follow-up, sir. So what type of surgery in breast conservative surgery or onchoplastic type of surgery versus mastectomy? What should be our preference, sir?
Unmute, please.
Thank you very much for the question. Hello,
sir.
can you hear me?
Sir, you're audible, sir.
First of all, thank you very much for inviting me to your panel.
Professor Farooq, we cannot listen. We cannot hear you. Unmute yourself.
Sir, unmute, please, sir.
Unmute yourself, please.
Now, can you hear me?
Yes, sir. Now
Yes, sir.
you are unmute.
Society of Surgeons for inviting me to be one of the panelists.
Sir, volume louder, please.
It's a wonderful
Sound is disturbed, sir. You better, sir, remove your earphones, sir.
I think I have it. I think I know the solution here. Just a minute, please.
Sir, Farooq sir. Omar Farooq Yusuf sir. Sir.
Sir.
So slowly, sir.
Am I audible now?
Audible but slow, sir.
Slow bolte ki bulacho?
Less clear, sir. Volume is too low, sir.
এখন better?
স্যার ভালো শোনা যাচ্ছে না স্যার আপনার স্যার একটু জোরে বলতে হবে অথবা স্পিকারের কাছে নিতে হবে
স্যার আপনার যে আপনার স্পিকারটা খুলে ফেলেন স্যার আপনি নরমালি বলেন
বুঝতে পারছি না হেডফোনটা খুব ডিস্টার্ব করছে can you carry on with somebody else until I sort out this headphone please
হ্যাঁ এখন শোনা যাচ্ছে স্যার
এখন শোনা যাচ্ছে please continue now we can hear you
okay
okay
এখন
now better
yeah okay once again sorry for the audio visual problem thank you very much Society of Surgeons for inviting me to be one of the panelists and it's been a very enlightening conversation and it's a wonderful opportunity to see Khadim Bhai and Marhum sir and all the others. Assalamu alaikum to all of you. It's been a long time since we've seen you. Mukhlis Bhai also and all the other junior colleagues apart from the senior mentors. The question that you put up about the follow-up, I think that's a very difficult question to answer because for the follow-up and following breast conservation techniques, one needs to have a good infrastructure. Then the patients must be aware. So I think counseling here would be an important factor, letting them know how important it is that the follow-up for them. And apart from that, I think now in Bangladesh, follow-up is much easier now because we are very well connected through mobile phones and through the internet. And thanks to this coronavirus pandemic, telemedicine has also has taken a boost. So I think follow-up this is one of the positive fallout of the pandemic. And about today's presentation, I must congratulate Professor Nizam. I had the opportunity of working with him as an assistant registrar, and he was the registrar at the time. So, Nizam bhai, assalamu alaikum. It's always nice to see you. But I don't remember the beard. So, Nizam bhai has opened up many frontiers for us on plastic breast surgery. I think it's up to the faculty members who are in the government medical colleges, particularly, to promote this oncoplastic surgical techniques, because they also have the advantages of having their plastic surgical colleagues who would be very useful in having a multidisciplinary approach. Apart from that, the only question, possibly a question that I have to Nizam bhai is that what about NCCN guidelines for oncoplastic surgery? What are the current guidelines under NCCN? Nizam bhai, unmute করেন, শুনতে পাচ্ছি না।
শোনা যায়?
স্যার হ্যাঁ, মিজান স্যার শোনা যাচ্ছে।
সব মিউট করেছিল তো না, রিকনস্ট্রাকশন তো গাইডলাইনে থাকে না, রিকনস্ট্রাকশনের জন্য আলাদা থাকে। এখানে এক কথায় কনজারভেশন হেডলাইনে রিকনস্ট্রাকশন গুলো আসবে এরকম আর কি। সে প্রত্যেকটার জন্য রিকনস্ট্রাকশনের জন্য আলাদা আলাদা জায়গা আছে। এনসিসিএন এর জন্য পলিসি মেকিং ইস্যু গুলোতে এই বড় বড় গাইডলাইনে তারা কথা বলে।
আপনি কি মনে হয় এগুলি কোনো এক সময় আসবে যে মানে আপনার মধ্যে আপনি যে সমস্ত টেকনিক গুলি দেখেছেন, it seems that the oncoplastic surgical techniques will sooner or later replace the traditional BCS techniques.
হ্যাঁ স্যার, তা তো বটে, এবং বিসিএস করতে গেলে টু সাম এক্সটেন্ট অনকোপ্লাস্টি জানা লাগবে, তা নাহলে ওই ডিফর্মিটি অনেক ক্ষেত্রেই হবে। ইন দ্যাট কেস দেখা যাচ্ছে ম্যাস্টেক্টমি বেটার ছিল।
Thank you, Mizanda, for the answer. Our nuclear presentation was quite extensive. The arguments will be, আমি জানি না ভবিষ্যতে আমাদের chemotherapy রোল চলে আসবে কিনা, depending upon the sizes and locations of different preference. Before I conclude, Shaheen, আমি জানি ওই যে lymph node palpable axilla, এটার ব্যাপারে আমরা অনেক আলোচনা করেছি। ডক্টর ফরিদের কাছে এবং ডক্টর মুকলেশ ভাইয়ের কাছে আমার একটা প্রশ্ন থাকবে। is there a need for simply giving neoadjuvant chemotherapy in such cases and not going for axillary clearance? Answer from Dr. Farid first and from Mukhlis bhai afterwards.
Thank you.
Thank you, sir.
Mito.
Sir, Farid sir, please.
I think now from panel of experts.
Sir.
Already this is 9:21. Okay.
Okay.
Comment from. Shaheen, আমার আনসারটা দিতে হবে তার আগে, please.
Acha, if I'm allowed, আমি বলে দিচ্ছি, I will take 30 seconds. In fact, there is much role of considering neoadjuvant chemo for this person, because there are aims and there are certain goals for neoadjuvant chemo, and this person may not qualify most of those goals or aims. Typically, downstaging of the cancer so that it could do breast conserving surgery. It also information or other things, but because the patient has already had surgery, excision biopsy, a completion axillary clearance is important, followed by staging. If patient has got more than 4 positive nodes, this is staging CT chest, abdomen, pelvis, and a whole body bone scan, followed by adjuvant chemotherapy based on patient's age and other facilities, and then radiotherapy to supraclavicular fossa, breast, internal mammary chain, and based on immunocytochemistry, further treatment. Thank you.
Thank you.
Sir.
Hello, moderator. Sir. Can I comment? Can I comment?
Sir, please. Hello, sir.
Yes, what the police says is absolutely right. It is absolutely right. There is no need of the adjuvant or de-adjuvant chemotherapy. For the axillary lump, but there is no lump in the brain even after MRI. What the management said, it is absolutely valid and absolute, and it should be followed.
Okay, sir. Thank you, sir. Sir, Margup, sir, please, your decision is the same, or you want to add, sir, something? Margup, sir, please.
Sir, unmute, sir. Professor Margus, sir, unmute, please, sir.
Margup, sir, please.
I go with the same decision that if you don't get any lump or any focus in the breast, don't go for doing anything more than axillary clearance if there is more than 3. And if there is more than nodes, then you can go for chemotherapy or any other things, because she is then be fit for some sort of adjuvant therapy. Otherwise, load or 1 or 2 nodes, but no lump or nothing in the breast, scan or MRI or then just wait and see. Why do you go for a mutilating surgery?
Okay, sir.
For that lady? No. I go with them.
Okay, sir.
Thank you.
Sir, another, thank you, sir. So, thank you everyone for active participation, my dear teachers and your here present participants. Everyone to make this session fruitful.
We like to hear from Professor Daud. He's one of the panelists.
Right, sir. Okay, sir. Daud, sir, please. Do you want this add or subtract? Hello,
No.
Daud, sir.
Yes, thank you very much.
What's your comment, sir, please?
Yes, thank you very much. I'd like to give thanks to the speaker. Both the presentations were brilliant. The Professor Mizan has discussed everything regarding surgical options of the breast cancers, like breast conserving therapy, mastectomy, oncoloplastic surgery, conservative mastectomy, like nipple sparing mastectomy, uses of the spleen, decision making, etc. And he also mentions things for the juniors, that is the training and diplomas who are interested in breast surgery. Actually, we know it's a lots of controversies still exist in breast surgeries. Actually, it differs when we are a student of FCPS. Then there are several discussion seminar. Everything it has been discussed actually in that. Actually, one of the important thing was that the session was overall excellent, but there was some nuisance. I don't know who created this. I think the moderator or who are in admin plane, they should control it very strictly, because somebody was singing Hindi songs and somebody writes some bad comments over the screen. I think in such a type of brilliant discussion and presentation with all quality doctors, it is not acceptable. That we should consider. Last of all, আমি যেটা বলতে চাচ্ছি যে yes, regarding the যেটা দুইটা ইস্যু আসছে, ইস্যুর মধ্যে লাস্ট ইস্যু যেটা ছিল যে lymph node পজিটিভ বাট নো প্রাইমারি, I do agree with all যে যেহেতু আমরা প্রাইমারি সাইট খুঁজে পাচ্ছি না, there no need to go to mutilating surgery, only the local management, that is enough. আমার মনে হয় অনেক সময় হয়ে গেছে, আমি আর সময় নিচ্ছি না। সবাইকে ধন্যবাদ জানিয়ে আমার বক্তব্য শেষ করছি। থ্যাংক ইউ অল।
Mito. Hello.
I think
Hello?
she's out of connection. She's out of connection. You please continue. She's out of connection.
Not in connection, sir.
You please continue.
Hello.
I think some problem with internet connection. Yeah, me too. I can see you.
I continue, sir. Now I would like to request.
We
Sir.
can see Mitu. Mitu is in the screen. Mitu, please, can you hear me?
So in that case, I would like to request Professor Kazi Mostaq Hussain, sir, Director, National Institute of Cancer and Research and Hospital. Professor Kazi Mostaq Hussain, sir.
Thank you. Thank you for inviting me in such a great presentation. I congratulate both the presenters. And it's a really a good thing for us to learn many things. Thank you, the participants in the discussion. My teachers are there. I thank everybody. And nothing to say about the controversies, and there will be controversies, and we will learn day by day, or every day there are new updates in the guidelines, and we are getting these guidelines which should follow, and we can discuss ourselves. And what I think we are lacking in our country, many things. We do not have a culture of multidisciplinary team approach. We still do not have core biopsy facilities in the district levels of our country. Frozen section is also not available in district level outside Dhaka. Immunohistochemistry facilities are very, very limited in our country. We do not have a provision for genetic counseling for family history and genetic counseling. So when I was in Tata, I saw in 2010 that they have a cell for this genetic counseling. Whenever they find the patient with the positive relatives, they follow those families. They contact them and they follow this. So now they have built a big institution for this genetic counseling and investigations. We still we are lacking radiation facilities too. Only a few centers are there, but according to the WHO or international guidelines, we need more than 300 machines, at least 180 centers, cancer centers with radiation and cancer centers, which includes the surgical, radiation, medical oncology department. We do not have these facilities yet up to the world level or standard level. And our patients are very poor, very illiterate. They do not follow the instructions, what you say. They cannot follow the advices for regular follow-up, which is very important. People cannot come regularly in the follow-up schedule. Everything, we have many limitations. And lastly, I want to say that in this October month, as we celebrate worldwide as the Breast Cancer Awareness Month, we should arrange these programs in a different group of peoples, involving the different groups, so that the importance of the early detection, screening program, self-breast examination, we can share these messages to the common people, so that we can have them in early stages. Otherwise, the treatment and the outcome of treatment will not be satisfactory. So I want to leave now. Thank you very much for giving me the opportunity. Thank you.
Mitu. Hello. Mitu ki connect aso?
Mitu, unmute yourself. Unmute, please.
Connected, sir. Sir, connected.
তো আমরা এই যে ছাত্র বলে ফেলছেন ফারুক স্যার এবং খাদেম স্যার কে বলো, ফারুক স্যার এবং খাদেম স্যার।
Sir. Sir, I'm inviting Professor Farooq sir. Farooq sir.
Thank you very much. I just want to thank everybody for participating. Thank the speakers for the presentation, and thank the participants. Thank you so much. Wonderful to see everybody.
Thank you.
I think now it's my turn to say a few words. Am I audible?
Yes, sir. Yes, sir. Audible, sir. Please, Khadam, sir.
So already, as participant, I have already interacted about the issue of lymph node or positive metastatic node in the axilla without visible or detectable primary in the breast. Now it's my turn as a panelist to put some comments. Definitely, today's webinar, the two speakers, I would congratulate them. But again, I like to mention that it was grabbed during the Professor Moklis Surama's presentation. And Professor Mizan, he is one of the a pioneer in oncoplastic breast surgery in Bangladesh, and I would expect that he will carry on his effort to modernize the treatment of breast cancer in our country. And I enjoyed his presentation very much. And also Professor Mokles' presentation, though it was very interfered by someone intentionally. And in the breast cancer is one of the very, or breast disease is one of the very important disease of the female, and number of breast cancer is increasing in our country like globally. And also the concern is more and more patients we are now coming across in the premenopausal, even in their early 30s. As Professor Mizan has given one case scenario that the patient is only having 28 or 25 years old. So we must be aware about this situation that we are facing more and more patients of more younger age group, and but are now privileged that many facilities, though not exclusively available, but now it's available like frozen section, like immunohistochemistry. So wherever possible, we should utilize those facilities. We should try to find out the cases in their early disease, and we should very actively think about the multidisciplinary that Professor Mustaq has mentioned, that this culture is not in our country, but we must have to try our best to deal the breast cancer or any oncological patient as a multidisciplinary approach. So with these few comments, I again like to thank the organizer and the congratulate the speakers. Thank you, everybody.
Thank you, sir, for your valuable comment. And now we are already nearer to the end of the session. This is time for the concluding speech. So may I request Professor AHM Tawhidul Alam, sir, President of SOSB, for concluding speech. And thanks everyone for patience hearing. Bye-bye and stay safe. Thank you.
Thank you, Dr. Mithu, for your nice moderation. Yeah, please.
Sir,
Do you want to say
sorry,
something? Do you want to
sir.
say something? Please. Shaheen, do you
No,
want
before
to say something?
Sir, before yes, sir. Before conclude the session, we again declare that there are another program in this month, 28th October. So we will invite all of the participants. Please also join with us in 28th October, 8 p.m. Thank you, sir.
So thank you, Shaheen. In this month of Breast Cancer Awareness Month, to the second day of our webinar organized by the society. First of all, I would like to thank to both the speakers. Particularly, I enjoy the presentation of Professor Mizan. His presentation is excellent, and definitely he has touched all the points, and I thank him for his masterly presentation. And secondly, our another speaker is Dr. M.B. Mukhlesuddin, Professor Mukhlesuddin. He has also very vividly described all sorts of management. That is, he is the master in that part, and he has described all the things. And actually, this is as we all know, the breast is a multidisciplinary subject. So at least we could we are able to at least gather two specialty here for to share their experiences in this field, because considering age, parity, and everything, this breast is a beauty for the lady. So this is a very, very difficult area to manage, considering all these points. So we need multidisciplinary approach if you want to conserve the breast. So everything has been discussed. A small, you see, a very small point. There is lots of discussion and a lively discussion on that at a particular issue regarding axillary load positive, no tumors in the breast. So you see, in this sub discussion, not only the we get benefited, also the other students, those who are listening this webinar, they are also benefited from these tricky points. And secondly, I would like to thank our 4 renowned panelists. They are the legendary surgeon of our country and medical oncologist, particularly Professor Khadimul Islam, Professor Omar Farooq Yusuf, Professor Kaji Mustaq Hussain, and Professor A.K. Daud. I thank all these 4 panelists, and I also thank to Professor Margoof Hussain, the senior most professor. I know he is physical now; he is a bit sick. Still, then he follows all our webinars, and I think he was the first man to join this webinar. I thank sir for his for his encouragement, because when we see the senior people joining with us, we are really encouraged. And lastly, I thank our other senior professor I'm seeing in the screen, and particularly Dr. Farid from UK. He has also joined with us and shared his experience with our audience. And with these few words, I'd like to invite you in our next session in 28th of this month to join our last webinar. And thank you, everybody. Good night. Good night, everybody.
Thank you, sir.
Most welcome. Most welcome.
স্যার খাদেম স্যার, থ্যাংক ইউ স্যার, মিজান স্যার, সবাইকে থ্যাংক ইউ স্যার, এবং আমাদের মোখলেস স্যার, মারগুফ স্যার, থ্যাংক ইউ স্যার।
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.